for AMR. Of course, you know, we have the resources. We have the will. But what best model can we use for the state-level surveillance? And then lastly, whatever gap analysis we do and the recommendation, we will take it as a roadmap to comprehensive, sustainable strategy for lab strengthening to deal with AMR in Katsina State, and also as a catalyst for other recurrent diseases. Because whatever model, whatever roadmap we build, we are not only doing it for AMR. Principally, it's for AMR, but it's for all other diseases. So we desire and expect to build the capacity for state AMR surveillance, improve healthcare outcome through better diagnosis, and it's our hope to inform policy, decision, and intervention to address threats of AMR from the outcome of this workshop, and then provide a model, as I said. The most important thing is that we will succeed in developing a model. What best model of AMR surveillance system suits Katsina State Health System is what we, and then guide the government, State Council of Health. I know we have State Council of Health and other stakeholders on the action plan. I'm not sure whether you have the action plan for health or health security plan for Katsina State. Is it available? The state action plan on health security, is it available? I'm not sure. Well, even if it's not sure, we have the Council of Health. So this, since we have the National Action Plan, it's what we are going to domesticate. So in this workshop, please, I know we have eaten now. We need full energy, and we have ground rules. After this, we are just going to present. Once we start, please respect these ground rules for the workshop. Respect and professional conduct, punctuality, focus, confidentiality, constructive arguments, discipline. Please, we need full concentration. And we need to discipline ourselves about even eating. Eating, I think, takes a lot of our time. We could see that we are dealing with almost half of the audience. So from today, inshallah, we are going to have a very good system and follow of time management, so that our time will not be wasted at the moment. So that's the end of the ground rules and the overview. Thank you very much for that.
Thank you, Prof, for the wonderful overview. So now we are going to take a pre-test. So please, I will urge all of you at the back seat, please, can you just move forward so that we block the space? Please, try and move forward. We are going to take a pre-test. So for us to assess our knowledge, to see the impacts of the workshop, we need to assess our knowledge at the beginning of the workshop, and then we compare with the assessment at the end of the workshop, so that we see the impacts of the knowledge we have been acquired during the workshop. Please, come forward, come forward. So, Professor, how many minutes are we giving for the pretest? So, okay, it's going to be 20 minutes. MPs, media, please, can I have a timer on the screen? Can I have a timer on the screen? A stopwatch or a timer, either one. Yes. Don't start until we said start. It's not a do or die affair. Just answer what you feel is the correct answer. Don't panic. No one is going to take post position or second or third. It's just to assess your knowledge, to know at what level are you now, and then at what level are you going at the end of the workshop. Don't start until we said so. Are we ready? MP's media, please. Can we have the timer? Oh, I should use my phone. Okay. If you don't have a copy, please indicate. Everyone is with a copy? Okay. Yes, okay. So it's 12 minutes, or let it be 11 minutes to 3. So we are stopping by 9 minutes after 3. Okay, you can start. We are stopping 9 minutes after 3. Good luck. Not the former president. Yes, don't look at your neighbor, just concentrate. It's just an assessment. Okay, don't forget to write your name at the top, your full name, because there is going to be a pre and post analysis. So please write your name. Then is a multiple choice. You don't need to write for every option to write whether if it is true or false. No, don't do that. Just pick the right option. Is a multiple choice questions. Write your full name. Take your time. Write what you feel is the answer. You have 9 more minutes. So I gave 10 minutes and no one objects. I don't know what happened. The prof said 20 minutes. Yes, now no one objects. So we are not stopping by 3:09. We are stopping by 3:19. We are stopping. No, if you want to. Khalid, can we have more papers here? Jeremiah, please, can we have some? It's just to assess your knowledge. No harm. Yes. They are professionals. They are trying to demonstrate themselves. Sorry. Someone said AMR is in trouble. Yes, no. Filin ku kawo zan tuna muku asiri a cikin mall. Wallahi sai na tuna. Ko ya rubuta. Ban lura ba wannan. Eh? If you do group discussion, there is no impact. If you are done, you can just raise up your hands. You can come and collect it. Some are done. Yana ganin masu group discussion go. Thank you. Yes. Sorry, sir. Yes, sir. Thank you. Nine minutes more. 20 minutes. So there is an appeal. We are going to reduce the time. So, the chairman, are we reducing the time? Okay. Some are done. Glass is glass, sir. Wanda zai sa. Kana iska? Ake cika. Khadija. Yau ga ta gama. Ba wanda ya ce a bada haifa. Ba mu a su a ci ayi. In ka ci da baka da amfani zuwa wasu. Yanki da suka yi ne. Go in the. Oh. 7 minutes. Okay, 3 minutes, go. No, it's not 3 minutes. It's not 3 minutes. Guys, do let it out. Yes. No, fam. It's not. Khalid. Four minutes. 4 minutes more. So Khalid, be at that point. When I said finish, you start collecting. Three minutes. Are we all done?
Okay.
Two minutes. One minute more. Please, let us have the papers back. The time is off. Please, let's have the papers back. Yes, let's have the papers back, please. Thank you very much for your time. A pretest is one of the tools to justify your presence here and also to give us a feedback of why we all gather here. Okay? So next to pre-test, we are going to take a presentation, global threats on AMR and the global action plan on AMR, which will be presented by Professor Bashir Abdulkadir. You're welcome, sir. Please, a round of applause to Professor Bashir Abdulkadir.
أعوذ بالله بسم الله الحمد لله والصلاة والسلام على رسول الله بعد السلام عليكم ورحمة الله وبركاته. I think we are working behind schedule, so I will take, because there are many presentations to come after this, so I will take us through very fast on the topic global threat on AMR and global action plan on AMR. This serves like the general overview of our conference, of our meeting here on the AMR presentation. I was given 30 minutes, but I was trying to go through it quickly on this outline. Global threats, the key statistics on the antimicrobial resistant free balance that give us why it's important to learn about this, and causes of AMR, consequences of AMR, AMR in fecal microbiota transplantation. Intentionally, I put this to give us more insight about the free balance and the international trends on this AMR and type of resistance to FMT, mechanism, strategies to mitigate FMT resistance, current guidelines for MT resistance, future direction, then second part, the global action, current status and gaps in AMR, recent milestone, strategic objectives, implementation of the GAP, challenges in addressing AMR, future direction, and the conclusion. As part of the introduction, that we have been informed that AMR is when the microbes, the international antimicrobial agent or the infectious agent responsible for causing any infections are mainly on 4 organisms: bacteria, virus, fungi, and the parasitic protozoans. So when any one of these evolve the mechanisms to survive and multiply despite the exposure to antimicrobial drugs, then we call that is antimicrobial resistant. So we have the antimicrobial resistance for virus, fungal, and the parasitic protozoans or the fungi. To drive as an analogy, I just gave this as part of the examples for the agricultural pest, that think of AMR like the pest becoming immune to pesticide. The more we use antibiotics, that is the pesticide in the case of agriculture, the more superbugs resistant microorganisms emerge, harder to control infection. So this increase the rate of that. Then, in general, as an overview, the AMR, the causes as we are going to see, then what are the consequences and the causes of that AMR, antimicrobial resistance, generally to the public. We know that AMR leads to ineffective treatment for infections, increasing morbidity and mortality rate. We are going to see the general statistic, that is the overall, the global statistic on the consequences on this. On the economic impact, it increased the healthcare cost and loss of productivity, due to longer hospital stay and more complex treatment. Then another one, the healthcare strain on the AMR, that common infection become untreatable, surgeries and cancer chemotherapy riskier, and the health system cost is soaring due to the AMR burden and disproportionate burden on LMIC, that is low and middle income countries, like in the Southeast Asia, Eastern Mediterranean, face the highest resistance rate and weakest health system capacity, as been discovered by WHO. And also the food security, resistant in agricultural pathogens can compromise food production and safety. Another challenge, global security, that resistant infection can spread across borders, affecting international health security due to the AMR. And also the case of limited treatment option, that fewer new antibiotics are being developed, resulting in reliance on existing medication that may become ineffective. Then what are the key statistics? Because whatever you do in science, you need to have the key statistics, that is to give you the basic why the AMR is so important, awareness campaign in combating them. Look at this, the current statistic as of this week. In the global mortality and morbidity, it is estimated that AMR was responsible for around 1.27 million deaths globally in 2019. That's from when the data collected from the World Health Organization, when they give the statistic, and directly and contributed to 4.95 million deaths worldwide, making it one of the leading causes of death globally. Projection warn 10 million annual deaths by 2015 if action stalls. That such kind of campaign, such kind of awareness we are doing, when we improve it, we are going to curtail or reduce all these numbers. But if care never is taken, then it will increase to this number, 10 million annually by 2015. Second statistic shows that infection caused by resistant bacteria are estimated to lead to tens of millions of additional infections each year. Despite we have the resurgence infection, emerging and re-emerging infection globally. The CDC has a website portal on the emerging and the emerging globally, whereby they are updating their sites on the additional infections that every year increasing. So if care are not taken on this AMR, so it will increase to 10 millions of additional infection every year. And in the hospital infection, they say up to 50% of the patient with infection caused by MDROs in hospital face higher mortality rate and longer hospital stay compared to those infected with non-resistant strains. There are some infection caused by non-resistant strain of microbial. There are those caused by these resistant. So this one is another threat for that. And on the economic cost, the statistic, it shows that AMR can exceed $1 trillion annually by 2015 if left unchecked, considering healthcare costs and lost productivity. $1 trillion by 2015 as a result of the AMR resistance. This economic impact of AMR could shape up to 1 to 3 trillion of global GDP yearly by 2030 and push 24 million people into extreme poverty. So you see, it's affecting our economic status, affecting the cost in the medication and in the health line. And also in the consumption of antibiotics, global consumption of antibiotics rose by 39% to 2000, and by 2020 to 15, it increased up to 39%. due to, and mostly in low and middle income countries, and the country like ours, the African and others, and in the Asian, South Asian. And AMR in agriculture, significant proportion of antibiotics, up to 80% in some regions, is used in livestock, contributing to the emergence of resistant strains, which cause a lot of setback in the agricultural sector. The causes, as we knew, over-prescription and self-medication. We knew that now, more especially in our countries, everybody is a prescriber. Everybody is a pharmacist. You prescribe and give it to your younger ones, give it to this, you give it to that. So all this over-prescription and self-medication is one of the causes of this AMR. Agricultural use of antimicrobials in the treatment of livestock infection. Poor quality or counterfeit medicines also contribute towards the AMR. Weak regulatory systems. That's why we have been told in the morning that, so it needs all this multi-sectoral approach. The policy makers, the health professionals, and the community, because we need to give a lot of awareness to the community leaders and everybody in the community so that we reduce the rate of this AMR. Environmental contamination, poor sanitation and hygiene. Also, they are one of the causes, because the strain, the microbial strain, develop resistance due to our environment. We know there is issue of gene mutation. Gene mutation, the microorganism get mutated in the genes, and based on the environmental influence. In the environment, you develop yourself, the microorganism there, they mutate, and that's the gene mutation, the change of all these, which contribute to the AMR. Overuse or misuse of antimicrobial in humans and in the animals, that's why we have that One Health approach. Overuse and misuse of antibiotics, inadequate prevention and control, that is IPC, inadequate prevention and control, also it affecting the AMR. Some of the consequences include increased morbidity and mortality, as we have explained in that statistic. Longer hospital stays. Now, most of the current cohort studies in the world, they use, whenever they are doing any infectious disease analysis, they use the period of this patient that are staying in the hospital, and they do what we call the follow-up study. Follow-up study. So even when the patient are being discharged, they'll follow them off, more especially with related to microorganisms, to find out whether those microorganisms are being resistant, and the resistance of those microorganisms, is it related to the environment, or it's not, or it's related to the gene. I was opportune during my PhD study in Newcastle Hospital in England. All the cohort study, I specialized on the neonatal sepsis infection in the Newcastle Hospital, England. So all our studies, we do pre, during, and post cohort study. So we follow up the neonates even after they have been discharged to compare the microorganisms and the type of antibiotics being administered to those neonates in tackling the neonatal sepsis. Then we have seen a lot of differences between the antibiotics they are receiving while during hospital stay and when they are being discharged at home. When we collect their samples, their stool sample, we come back in the lab, we analyze it. We have seen a lot of differences. Some they develop resistance after they are being discharged. So it means it's related to the environment they are staying. So hospital stay also contribute to what this AMR. Higher medical cost, limitation in modern medicine, surgery, chemo. Now, there are many modern techniques in combating the infectious disease in the world. That's why I put more emphasis on some slide on the FMT, fecal microbiota transplantation, because it's one of the leading modern techniques in surgery and chemo. because they say any infection caused by natural microorganism should be treated by using the natural means, not by artificial means. The risk of untreatable infection become harder, prolonged illness, severe complication, death, economic burden, need for more expensive treatment, limited treatment options available, rise in treatment failures. All these are some of the consequences as a result of the AMR wherever globally. Then, as a case study, I put this AMR in fecal microbiota transplantation. What we mean by AMR FMT, fecal microbiota transplantation. Now, they said the total number, when you take the GIT of the human being, one healthy human being, when you digest his GIT, that is the total number of microorganisms in the healthy human being, is more than the total population of the people in the world. It's the more than total population of the people in the world. So, means that most of the treatment infection caused by the microorganism in the theory of suppressive, dominance and suppressive. So if you have Mr. A diseased person, Mr. B, a healthy person, when you dissect the GIT of that diseased person, the type of microorganism you see on that person, as is developed, is one of the modern techniques now used to treat the infections caused by microorganisms. So when you dissect them, then you get another person who is healthy. Dissect, collect his stool, enter the lab, do the analysis, find out the microorganism. So the type of microorganism you see in the healthy person, because they are dominant, they are healthy. So when you transplant them into the diseased person without giving any drugs, so in the theory of dominancy and recessiveness, the number of beneficial microorganisms will suppress those diseased microorganisms in the diseased person, so he will get cured automatically. They have done that in the US and many countries, but the first cases they developed when they introduced this fecal microbial transplantation, as the way we do kidney transplant, heart transplant, liver transplant, now we do fecal transplant to treat the infection caused by microorganism. So in the first person, he's 60 years old in US. They do the transplant, but he died later. The transplant was successful. The fecal microbial transplant was successful, but he died later. They realized there is a development of resistance. The microorganism from the healthy person they put on him, he already developed resistance to that microorganism. So that makes them to introduce new policies, new, they recommend that, okay, before doing fecal microbial transplant, then you have to do the laboratory test to find out, okay, the person to receive and the donor and recipient, collect their sample, observe the total number of microorganisms in them, making a comparison to see if there is a resistance to one another. If there's a resistance, you should not do the transplant. If there's no resistance, then you do the transplant and it will be successful. So one of the way it developed that now the world are learning, understanding more about AMR is through this fecal microbial transplant. This is highly effective treatment for recurrent Clostridioid difficile infection. This is the current name of this organism from 2016. It was named Clostridium difficile infection. But now the Clostridium is an old name. It's been replaced with Clostridium difficile infection due to the gene, the new strain gene of this organism has been developed. So with cure rate exceeding 90%. That is the cure rate of this FMT, fecal microbial transplant. It's more than 90% now. That's why we say it's one of the modern techniques in the treatment of infection caused by microorganisms. However, the risk of transmitting antimicrobial resistant organism through FMT is still a growing concern. That's why they are developing a lot of research in AMR in order to address this. Then the type of resistance to this FMT, fecal microbial transplantation, one, multi-drug resistant organism, MDROs, as the bacteria resistant to multiple antibiotics such as carbapenem resistant Enterobacteriaceae and extended spectrum beta-lactamase producing Enterobacteriaceae. So this is one of the resistant MDRO. Second one, VRE, vancomycin resistant Enterococci. And number 3, extended spectrum beta-lactamase producing Enterobacteriaceae. Also, they are part of these resistant. Then, what are the mechanisms of this FMT resistant transmission? We have 2 mechanisms: donor-derived resistant and recipient-derived resistant. In order to avoid this resistant transmission of resistant bacteria from the donor to the recipient through either FMT, then the selection and expansion of pre-existing resistant bacteria in the recipient. So when they are matched, then you will go ahead with the transplantation. If they didn't match, to avoid the resistance, then you take note of that. Strategies to mitigate this: 1, donor screening, as we said, stool testing of donor stool for antimicrobial resistant organism, including PCR-based assay and culture-based method, recipient monitoring, antibiotic stewardship, FMT protocol optimization. All these are part of the strategies to mitigate the FMT microbiota. The current guidelines for FMT resistant: 1, FDA guidelines and Infectious Disease Society of America guidelines. These are the 2 current guidelines in order to address the resistance of bacteria due to FMT. Future direction for this FMT: to develop standardized FMT protocols. I'm bringing all these so that we in Nigeria, because we are talking globally, so that we can adopt, we can develop this in our strategies, in our Nigerian action plan, in Katsina State action plan for that. Improve donor screening, recipient risk stratification, alternative therapies. And the action plan, I said, by implementing these strategies, the risk of transmitting antimicrobial resistant organisms through FMT can be minimized, ensuring the safe and effective use of this life-saving treatment. Then on the global action, you are still in 3 minutes, but I will quickly go through them. That use antimicrobial judiciously, improve hygiene, develop new drugs, promote One Health, aims to GAP developed by WHO in 2015. You see, the practice now in the Europe, in the developed countries, you can't not go to the over-counter for someone to give you a drugs, to buy a drugs. No. They are only selling, you can go free. Any pharmacies, they will only give you the pain reliefs. But any hard drugs, any antibiotics, it has to be prescribed by authorized person and has to be given by a pharmacist, not anybody. So these strategies, they are reducing the issue of ART. But in our countries, you go anywhere, go to any pharmacist, any drug selling, you will buy antibiotics, hard antibiotics, you will buy them. That's why the resistance is more in our countries than in the developed countries. The current status of gaps in AMR, as of November 2023, 178 countries have developed national action plan aligned with AMR. Another colleague will talk about these NAPs. So I will not talk much because somebody is coming to talk about them in detail. Progress on even that many low and middle income countries struggle with this implementation, financing and multi-sectorial coordination, COVID-19 setback, One Health integration. All these are part of these strategies. The recent milestone on global action plan on AMR, as of in 2024, Ungan high-level meeting adopted a political declaration with 10% reduction target for AMR-related death by 2013. That's why in the morning the representative of chairman, he explained about we need to put our hand together with the politicians, the policy makers, and others. World AMR Awareness Week 2025 as declared in November 18 to 24. That's why our Katsina State scientists, they try to put this program within this, so to address this. So this is part of all this action plan. Our future launched the regional roadmap 2025 to 2030 for South Africa as developed by the WHO and others. I want to show us some, let me skip this, implementation of the global action plan, challenges in addressing this, limited access to diagnostic, as we have been heard from the policy makers, from the administrators of this, what they are doing in Katsina State specifically, lack of new antibiotic development, variability in healthcare infrastructure, behavioral change in antibiotic usage. Please permit me to emphasize on this. I say clarion call to health professional and healthcare provider to reduce AMR. Here I am talking to any health professional. Medical doctors are here, pharmacists are here, medical lab scientists are here, and all the other health professionals are here, whether you are nursing or not. I say common and best practices in administering probiotics and antibiotics to reduce AMR. This is one of the issues either knowingly or unknowingly commonly attributed to increase the AMR in our communities, which need the multiple approach. I say administering antibiotics with probiotics can be a strategy to reduce the risk of antimicrobial resistance. Here are some of the best practices. I supervise some student medical doctors, MBBS, in masters and PhD. As said by Dr. Amir, I'm medical lab scientist and supervise them in the MSc work and PhD work. They are practicing. We sat down, the topic I gave them while doing, I was asking them when they are, because my specialty in neonatal sepsis on all these probiotics, I was opportune to visit many countries and part of the Probiotic Association in Canada. I went to Germany, I went to Netherlands, in the UK. I've all presented talk on this issue, on the probiotics. So during my research, we have one Imploran capsule together with all the medical team, the consultant neonatologists, the one given to solve the neonatal sepsis in UK. So that Imploran capsule involves some beneficial microorganisms, bifidum, bacteria, and the lactobacillus acidophilum. So it's one of the best, but the problem lies now when you are taking antibiotics and probiotics. You know, probiotics supporting antibiotic, and we have symbiotic, probiotic, antibiotic, and prebiotic. There are 4 terms. So in the given probiotics, you know, we take yogurt now. Most of these beneficial microorganisms, we got them in our food. We consume as probiotic, as beneficial to give us health. But sometimes our common practice, you want to take antibiotics, you are under medication, then you won't take antibiotic, but you say, okay, I will take my antibiotic with cocoa, with spara, with yogurt, to be palatable for you for consumption. Those foods they contain beneficial microorganisms in them. And you are taking antibiotic, and you want those probiotics to be useful in your body. So at the end, you will have zero effect. You take antibiotic with fermented food. They say the best hygienic food on the surface of the earth is the fermented food. It's the fermented food. So the fermentation is taking place as a result of the work of the beneficial microorganisms, the bacteria. So when you are taking probiotics with antibiotic, at the end you have zero effect. Based on dominancy and recessive theory, if the antibiotic you are taking are more in number than probiotics, they will suppress them. So at the end, you just take concoction. And if what you are taking in the probiotics, they will kill the antibiotics, so you develop resistance. So they give when we are in UK, the advice they give in the best practice is 20-minute interval. I used to coach all my medical, my students, MSc, PhD, those are medical doctors. I asked them, how are you giving antibiotics to the neonates when you hospitalize them? He said they give them anyhow. I say it's wrong. This is how to do it. 20 minutes. When you are giving a patient antibiotics and he is taking probiotics, any food with a probiotic content, then give 20 minutes before and after. When you want to give him to start taking the probiotics, then do not give him any antibiotic until after 20 minutes. Or when you give him antibiotics, do not give him probiotic until after 20 minutes. So that's why we say use probiotics that are resistant to the antibiotics. Choose probiotics that are inherently resistant to the antibiotic being administered, ensuring the probiotics survive and maintains good microbiota and prevent dysbiosis, what you call dysbiosis. So the clash, the imbalance of the microorganism in your GIT will affect and will help to develop this AMR. Select probiotic with multiple mechanisms of action, like lactobacillus and bifidobacterium have multiple mechanisms making it harder for pathogens to develop resistance. I use this microorganism all in my studies in UK, in Germany, and with the company that they are even producing them when we are administering to the neonatal and attacking the neonatal sepsis. I say administer probiotics at the right time. Give probiotics a time interval before or after antibiotic consumption to utilize their effect and avoid the risk of AMR. Administer probiotics before and after antibiotic treatment to help restore gut microbiome. When you take when you are taking the prescription or the treatment, so when you give probiotics, give antibiotics before the treatment. After treatment, give another antibiotics so that to balance. Or give probiotics so that they will suppress, they will multiply, so that they will give you what you want. We say use probiotics with high CFU, that's a colony forming unit. The colony forming unit for probiotic is 10 billion colony forming unit can effectively colonize the gut and support microbiota recovery. So when you are selecting the type of probiotic to consume, don't go any food item you are buying. If they contain probiotics, look at if they specifically specify the type of the colony forming unit. If it reach up to 10 billion, then that one is enough to suppress any probiotic so that it will help to recover. So now in medical line, we are always encouraging using the natural means to maintain your health than to be using the artificial. Then monitor patient for AMR and side effect. Track patient for sign of AMR, allergic reaction or other adverse effect. It's what happened in America when they start doing the FMT, fecal microbial transplant, because the patient, the process was done successfully, but later on he died due to resistance in the E. coli developed in his body. So clarion call to some commonly used probiotics. I say the most commonly used probiotics that are multi-resistant with all those characteristics we mentioned are these: Lactobacillus acidophilus, Bifidobacterium bifidum, Saccharomyces boulardii, and Streptococcus thermophilus. I use all these during my studies when we are handling the neonatal sepsis, specifically in the neck, necrotizing enterocolitis among the neonates, which is one of the devastating and catastrophic disease affecting a lot of the neonates. And we even leaded the team in the UK. I'm part of the neonatal research team in the UK up to now, and we publish a lot of works in addressing all this, including the resistant antibiotics in attacking the neonatal sepsis. When selecting probiotic, consider the factors like strain specificity, CFU count, survival in the gut, interaction with antibiotics. I say consult with a healthcare professional or pharmacist to determine the best probiotic and administration schedule for specific patient and antibiotic regimens. Summary and future direction: understanding the AMR, strengthening knowledge and surveillance of antimicrobial resistance, prevention and control, optimize use, research and innovation, multi-sectorial approach to all this. What are the quick takeaway messages from my presentation? Improve awareness and understanding. This is part of it. Strengthen surveillance and evidence, reduce infection incidence, optimize antimicrobial use, drive innovation and the financing. I say call to action for healthcare professional, policy makers, and the general public. Thank you. The bottom line, I say AMR treating global health and economies on catastrophic scale, but coordinated action through the World Health Global Action Plan, reinforced by One Health Partnership and updated national action plans offer a structural path to curb the crisis. Continuous investment, equitable resources allocation, and stronger governance are essential to translate commitment into measurable outcomes. These are part of the links on the AMR for further reading in the global AMR threats and the action plan. Thank you very much.
Thank you very much. Please, another round of applause to Professor Bashir Abdul Qadir. There is a wide saying that goes around, when you allow professors to talk, they can talk from morning till sunset. So from now on, we'll be attaching a timer to the wall so that we'll keep to the time. And I don't know, sir, are we taking questions now? Or we at the end of the session? What do you suggest, sir? Because we are really behind schedule. Yes, sir. We leave the questions from center. Thank you very much. Another round of applause as he stepped down. Thank you very much, sir. So I know the participants, as we hold our pen and jotter, now we have had the course, the strategies, the challenges, and also the current guideline. So don't be scared. In the near future, we'll start taking feces as form of remedy, which is very shocking. Okay? So for the action plan, if you are following us, it was developed 2015. Then we observed 5 strategic objectives, of which Prof also dived into the recent milestone, and we also look at the challenges in addressing AMR. And very importantly, at the end of his presentation, he dwelled on the clarion call. Okay, so without wasting much of our time, we'll take the next presentation before we break out for prayers. We are going to take another presentation from a renowned Professor Farouk Sarkinfada to present on National Action Plan on AMR, specifically in Nigeria. Please, a round of applause as he comes forward. Let's encourage Prof. Well, Prof means business. So, well, are we safe? You know, you cannot talk about AMR in Nigeria without mentioning Prof. Farouk's name. Whenever you say AMR, you have to say Sarkinfada at the end. Thank you very much, sir.
Oh, thank you very much once again. Yeah, it's not like comfortable to speak while in Babariga. I thought it's just opening ceremony. Well, I will suggest making the 2 presentations in one. This National Action Plan is part of the next presentation on One Health, please. So, and I think to give details about National Action Plan may not need or require a complete presentation. So please, may I urge you to just present the One Health, so that in the One Health I will incorporate National Action Plan because it's part of the process. So that will give us the 2 presentations in one. Yes, I think this is okay. So before I continue, can I identify the diversity of health workers we have here? Do we have medical doctors? One only? Yeah, I just want to make sure that we are talking to One Health. What of pharmacists, please? Are our pharmacists around? Okay. What of environmental scientists? Okay. So all the same, we've heard about the global threat of AMR, and I think my presentation, in order to be very easy, I will talk most from experience rather than reading the slides. Because I just want us to understand why we are here. Because whatever I'm going to present here is in the context of what will be the output of this workshop. The output of this workshop is to know how to have a functional and effective surveillance system for AMR in Katsina State health system. So, and all of us here, including those who are not here, are stakeholders. So what should we know as One Health? And what should be our responsibility? Because each and every professional, including the media, have a stake in this process. So when I talk One Health, I think it's well, that is why I said I will talk from experience of what I did before. And this is what One Health means. Multisectoral, multidisciplinary. So, in this workshop, we want to learn, or we want to develop ideas of how to be multisectoral and multidisciplinary in dealing with antimicrobial resistance. That is from humans, animals, and the environment. One of the presenters mentioned here that almost 70%, I learned of 60, but it's almost 70% of all the infectious diseases that affect humans are zoonotic. So this is where veterinarians also are relevant. Now, if 60 to 70% of microbial diseases that affect humans are from animals, can you conquer infections from humans only without dealing with animals? Impossible. And all these things take place in the environment. What is our environment? The air, the water, the food we eat. So, and detecting early prevention, reduce impact of infectious diseases. This is a demonstration of the threat. In this slide, we can see that it's a threat. The microbes gaining supremacy above humans. Okay? And that is why the WHO declared AMR a global health threat. Now, but interestingly, it was overtaken by COVID-19. If not for COVID-19, AMR might be the one that it's most issue of concern in health. And this statistic was given 20 to 30 years, it could bring a pandemic. Just imagine a drug-resistant or totally drug-resistant microbe that is that is deadly, spreads as a pandemic, God forbid. It could act as COVID as it was. These are the mechanisms. Okay? This slide summarizes the mechanism of how it becomes resistant. One, the efflux, the changing the binding sites, and so on. There are four major mechanisms by which the microbes have natural resistance mechanism against antimicrobials. Now, What does this tell us? Just like Dr. Amir was saying in the morning, 75 or 97 years ago, we didn't know about antibiotics until the work of Alexander Fleming. And the statement he made when he got the Nobel Prize that it wasn't permanent. It will not be permanent. I think you made this statement. Now the reverse is the case. Almost 100 years. You can see not only in human the misuse of antimicrobials in animal breeding, in fishery, just to boost yield. You may end up consuming antimicrobial residue. Not by taking the drug, by eating other sources, you can see. So the overuse of antibiotic for infection control, limited access, and the weak surveillance and reporting system. Now, if you look at the last 2 points, they are very relevant to our gathering here. Because we need to have a very strong surveillance and reporting system. And that is exactly what the Global Action Plan is about. And that is exactly one of the pillars of AMR, fight against AMR. And the lack of investment in research and development in new antibiotics, even though this is like debatable, because it has been demonstrated that even development of new drugs cannot solve the problem. You know why? Development of new antibiotics cannot solve antimicrobial resistance challenges. True or false? True. So why is that? They will develop resistance. And the answer is, this is what I want to show you as the answer. Permit me to go to this slide. I will go back. This is the real threat. You know, even new drugs may not likely be sufficient to combat the threat. Because in 2017, it was estimated about 8 of 51 new drugs. You can see the pie chart. 51 new drugs are in development. New antimicrobial drugs were in development that time. But only about 8 of them, which is what is the percentage you can see in the chart, that only 8 of them are likely to add value to the current antimicrobial arsenals we have in the world. So out of 51, 8 might add value, and the rest may not add value to the fight against microbes. And then the second reason is that the world is running antimicrobials, out of antimicrobials. Why? Because the rate at which the microbes are becoming resistant, compared to the capacity of humans to develop new drugs or new strategies in combating them, is wide apart. Meaning that the microbes have supremacy over humans. The rate at which resistance is developing, compared to which the rate at which we are capable of developing new strategies and new drugs, is wide apart. So it means we have to change strategy. New drugs are not the answer. So this is why we need a One Health approach. Because in One Health approach, we are not using like confrontational. What is confrontational? trying to develop antibiotics when we have resistance. But the One Health approach is to realize that the pathogens have no boundary, and we have globalization now, and the population increase, environmental degradation, the civil unrest. All these are factors that promote the spread of this antimicrobial resistance. This disease X is the one that was predicted that it will account for about 50 million deaths or 10 million deaths by 2050. And all these are factors that are reality. These 5 or 6 factors are a reality, and they promote spread of infections globally. So the essence of this point is that whenever there is a threat anywhere in the world, it becomes a threat all over the world. We have seen how the pandemic of corona. So this is the threat that any antimicrobial resistance, any pathogen that develops total resistance and is highly pathogenic, is likely to bring. When you say this, some people get jittery and say, is it real? It's real. And we have seen how corona dealt with us. And you can see the dynamics here of the relationship between what we said in the last slides. You can see how humans are affected by encroaching the animal ecosystem, and how infections can be, in the red curve is how humans are affected by zoonotic diseases. But this one is showing if there is early detection, the menace would be reduced. Okay, I have explained this. Now someone has mentioned these key strategies. These are the key statistics that shows its threat. Now these are facts that if you look everywhere in the Google, in other ones, they will give you this fact, and they are facts. So in all this, it is telling us that we need an action. Okay? All these statistics and threats of antimicrobials tells us that we need an action. And this action has started. When has it started? When the World Health Assembly declared AMR as global health emergency. When the same body developed what we call the global action plan that Prof has enumerated in his presentation. What is global action plan? Because this pandemic of antimicrobial is global, is no longer local. Because of the facts in those previous slides, international travels and so on. The action has to be holistic and global. So that is why it is a global action plan. Now the global action plan is translated also by different countries into the national action plan. Because we have this divide, the so-called developed countries and the developing countries, or the low and middle income countries. So meaning that if you have a global action plan, it cannot work the same across all over the world. Because there are developed countries in which the health system is very efficient, and they are rich with the political will to fulfill all that is needed in the global action plan. Some nations have strong surveillance system at the moment, whereas some are struggling even to develop one. I was in UAE in the last 7 years. In the last 7 years, we had almost 200 laboratories. As small as UAE, they have 200 network of AMR surveillance laboratory. The surveillance sites only. And that was when At the same time, I compared to Nigeria. When I came back in 2019 to 2020 to lead the AMR project, that time we had 3 reference laboratories and we were able to strengthen 18 sentinel sites, including animal and human and environment in total. Compared to a smaller country with rich things that have almost over 200. I know now they are over 200. So this is an example, practical example where the global action plan cannot be fully implemented uniformly. So what do we do to key into the global action plan? Develop a national action plan in accordance with our strength, in accordance with our health system that is implementable. So that is what was developed in Nigeria in between 2017 and 2020. And what we have to do now is it remains to domesticate or to step it down to the state action plan. Again, maybe the national action plan may not be uniformly implemented across the states because different states have different context of their health system. So that is the idea of developing the concept of this workshop. How do we guide Katsina state government to develop the best model of national action plan to create a state action plan on antimicrobial surveillance? We need to have a system. So you can see the glass is the global action plan. We have the national action plan, and there is wide range of readiness, like I said, between the rich and poor countries. You can see now why does the rich country must support the poor countries, because if the poor countries are made with AMR, the threat is always there also, because it's going to be a pandemic. So I don't need to go into the detail of the challenges. We all know the challenges of our health system. It's just like speaking to a convert, as the doctor may say. When we ask everyone to bring challenges of health system, we can continue saying it. Okay? So these are the basic strategies for One Health, please. And this slide contains what we may eventually by tomorrow have discussion about. Because if we need a One Health approach to AMR, there must be advocacy. It has already been advocated. You can see the FAO is food and drug, OIE is animal health, and WHO is human health. Now, improve antibiotic stewardship, that is for the doctors. In the clinics, in the hospitals, enhance surveillance and reporting, invest in research and development, strengthen infection prevention and control and awareness. So these are considered as the pillars. So for your information, my dear participants, yes, in the breakout sections that we are going to have deliberations on how best we can develop these pillars with what we have in Katsina State. Okay? And essentially laboratory. Of course, in our deliberations, we know best about what we have currently in lab and how best we can use our lab systems to strengthen AMR surveillance. Okay, so that is okay. And eventually, we cannot get enrolled into the global antimicrobial surveillance system without optimizing, without standardizing our laboratory system to meet the standard of detection and reporting. Okay? So, and for glass to accept any data from any country. That country or the facility that conduct the analysis and reporting must meet the standard of the lab system. So I know in this country there are some laboratories that are currently reporting to glass. Dr. Nasser, Aminu Kano is one, is it? Yes. So if I may ask Dr. Nasser, what does it take for Aminu Kano laboratory to report to glass? It takes years of, hello? Preparedness. And donors. How many donors? Flaming Fund.
Yes, then
audience, I just
also
want to
follow.
show you the practical example of how to belong to glass. Because I know the FMC Katsina, I think is the highest body here. Do we report to glass? So, Kano report to glass. Please tell us. Continue, sir. We still need because it's a practical evidence that we want to show. We want to be here. So if we want to be like Aminu Kano, what does it take, sir?
Yeah, you have to prepare yourself on the full implementation of the quality management system. And that needs mentorship.
Okay, mentorship.
From those that are implementing it. And then it needs training and retraining of the personnel. Then management commitments.
Okay.
Then you have to get registration with the HUNET.
Okay,
HUNET
HUNET
is the platform.
Information Management System.
Yes.
WHO net is the information management system that is used to report to glass.
Yeah.
Okay?
So when you are registered with HUNET, you do a pilot.
Sir, I just want to tell infrastructural development.
The infrastructure,
Yes.
of course, the lab has to be developed to conform with the requirement for AMR testing.
Yes.
Then the personnel must be trained to get the competency in AMR testing.
Mm-hmm.
The agents, the media, the reference organisms must be in place.
Yeah,
and must be
for proper reference.
Then the environmental control of the laboratory must be optimized.
Okay.
Yes.
So thank you very much. Why do I ask him that? FMC Katsina don't report. AKTH report. What makes the difference? Years of infrastructural capacity building, human and material development. And for your information, Aminu Kano Teaching Hospital was one of the 18 sentinel sites we developed with Flaming Fund, 2018, 19, 20. And I have the idea of what we spent in even renovation of the lab to meet the standard for antimicrobial testing and reporting. Even the construction, not to talk of materials, is multi-top there now? The multi-top machine, you see? Multi-top is needed for the, so you can see what is confronting us. If we want to suit into the global action plan, we need strengthening, we need capacity development for such kind of system. So summary of what exists in Nigeria, we said global. And that is why I say the National Action Plan. Nigeria has invested a lot in the last 5 to 10 years because we have the National Center for Disease Control. And in this National Center for Disease Control, there is what we call AMRCC, Antimicrobial Resistance Coordinating Committee. Is the coordinating body of all the activities of AMR, and all the donor projects that come will pass through the NCDC. So, and the National Technical Working Group was in place. There was secretariat in NCDC, and then situation analysis was conducted, and this document, strategic plan, was developed. And apart from this document, I think, which is expiry, we developed another one that is from 2003 to 2023 to 2028. So currently there is another new version of this document that has been developed for the next 5 years. So what we will do for the stakeholders in Katsina is to take this document, the new version, if we want to develop our own action plan to see how we can customize it. And you can see it obeys the One Health strategic plan. Now, these are what happens at national level also. We have a governance structure. So, when we want to create our governance structure in Katsina, we don't need to create one. It's only to look at the structure, the governance structure and responsibility that exists at national level. Then ask ourselves, can this work in Katsina? If it can work perfectly, fine. If we have constraint, then we can remodel and create our context. And the last 5 points are what we call pillars of AMR. When you want to build a system for AMR, you have to have the awareness pillar, the research pillar, the surveillance, which is laboratory, the stewardship, which is more of clinical, the biosafety and biosecurity, and infection prevention and control. So these are the pillars that eventually we, at the end of this workshop, we want to conduct a gap analysis for Katsina State on these 5 pillars from the participants. And just feel free, whatever you know about this context, let's bring ideas to put our heads together to guide the government. This is what I'm saying. This was the old governance structure for One Health, you see? It has the human, the animal, and the environment. And you can see the NCDC at the center, and the NCDC reports to the One Health National Steering Committee at the Federal Ministry of Health, the Technical Working Group, and you can see the desk officers. So one of the interventions that the Fleming Fund does in the last 5 years was to restructure the governance structure itself. Now this is the result, the National Action Plan. Is it? Yeah. This is the document. And there is a new version of this also, because it has expired since 2022. There is a new version for 5 years. Strengthen Nigerian One Health structure from the project. Validation meeting, this is the new governance. All these slides, I don't want to go into them because they are the steps we took practically in strengthening the One Health governance structure in Nigeria. But the result is this. You can see at the bottom there are the 5 pillars. We will use this model to create a similar structure for the health system in Katsina, if feasible. But if not feasible, this model is flexible, depending on the amount of manpower and structure we have. But at the bottom line, if you look at this, is awareness, surveillance, stewardship, IPC, and research. So these 5 pillars are very fundamental. You start from there. And once you have those structures at the grassroots, then you build the upper authority up to the national or up to the state One Health Steering Committee. Now these are the pillars again. Can we comprehend this? Because if you look at the 5 pillars, they are now horizontal. And these 5 pillars must be established across One Health. So first of all, we have the 5 pillars that we need to build. And if we need to build that 5 pillars, it has to come across the 3 sectors. That is the animal, the human, and the environment. So it depends on your capacity. If you have capacity, you could have up to 3 times 5 technical working groups. Because each component needs a technical working group to come with strategies on how to promote AMR awareness. We need a technical working group on human health awareness group, animal health awareness group, and then environmental health awareness group. And these technical working groups can be one. So if we don't have much capacity, we can create only one. So it can range from 5 technical working groups up to 15. Now you can see how flexible is this model from one country to another, even in the country from one state to another, depending on how strong is your human and material resources. Please, I hope this is comprehended, because we are going to work on this later, maybe tomorrow, in building our own strategic pillars for the state. So at the subnational level, as I said, we have to improve all these pillars. These are the pillars also that we have to have state One Health strategic plan. And this is all translated from the national. And I may conclude that Nigeria have a combined One Health AMR structure and minimize duplication. Then we need to establish national action plan, optimize laboratory capacity, and most importantly, the last point, sub-national, that is the state level. Once we have a state level strengthening for lab system, it will certainly serve as a catalyst. If you strengthen lab system for AMR, you are not strengthening it for AMR alone. It's a catalyst to strengthen the lab diagnosis for the entire health system. So it is like jifan tsuntsu dubu da dutse daya. If we strengthen capacity of laboratory for AMR, it's not for AMR alone. It's a win-win situation. So we are advocating at this workshop to work together towards ensuring mobilization, resource mobilization towards One Health structure, operational guidelines for AMR action plan, and lastly, develop sustainable or subnational level model for AMR and governance and the national action plan, based on the national action plan. So this is what might be our ultimate goal, and we hope with your contribution and those who are not here, tomorrow we may start with the gap analysis if possible. We can suspend presentations, and this gap analysis and proposal for structure is very important, because it's the practical approach, okay, from all stakeholders that we can have in having the result from this workshop, rather than didactic presentation, which is just like classroom teaching. So once we assimilate this idea, please, we want to deliberate on them tomorrow, and let's come up with what we can use in the context of ourselves. Thank you very much, and no questions, go? Do we break for the question? Okay. We break for 10 minutes for those that want to pray, then we continue. Okay.
Okay, please, another round of applause to Professor Farouk Sarkin-Fada. Another rich presentation from an erudite. I think we are going to take a 10-minute break. For those that will go and pray, then we'll take our last presentation by another elite professor, Professor Usman Ali Dusama. Please, we'll break out for 10 minutes and come back to take the last presentation. Then please prepare your questions. If you have any question, put them down and submit before the end of the last presentation. Thank you very much. When are we converging? In the next 10 minutes, please. Don't stay outside. When you're done, just come back. We'll continue in the next 10 minutes.